name is Radwan. I hope the voice is clear. I'm a fifth year medical student, and I'll be giving you this lecture. Most important thing for me is that whenever you have any questions, just unmute and interrupt me immediately. It's totally fine. Because you guys are second years, and I wasn't sure like how do you want this to be? Do you want me just to like explain everything or highlight the key facts or the most important things for the exam? I'm not really sure like how do you want it to be, and that's why like whenever you have any question, any comment, you can just unmute and ask immediately. So this is one of the most important lectures in the neuro for the neuro final as well, because it is the most important disease in terms of neurosciences. It's the second leading cause of death worldwide. And that's why when studying this lecture, it's very important to keep in mind that you're not studying it for the final, but you're studying it for your entire career, because you're gonna face it again in year 4, in year 5, and also, of course, in your internship, you will be like seeing a lot of stroke patients. It's a very common presentation to the emergency and also in the stroke units. So we'll start with the lecture. This is a clinical one, so we'll go over the pathology quickly, which is, I think it's the most difficult part. And then we will move on to the clinical aspect of stroke and how to manage stroke. So I think you all are already expert with the blood supply to the brain. There's really nothing to add anymore. We know about the anterior and posterior circulation and all of its branches. Most important for the circle of Willis in terms of stroke is that you are able to identify the homunculus. So that, like, if I tell you that the MCA artery is obstructed, then you know what will be the clinical presentation. So like face weakness, arm weakness, and so on. And also it's important to know that, of course, in the circle of Willis, there are many anastomoses and many collaterals, and this will affect our clinical presentation for stroke, because patients with who have extensive collaterals will have like a much severe disease than patients who don't have a lot of anastomosis and collaterals. I'm not gonna go over the branches of the circle of Willis. You already took it in your anatomy. So this is what I was talking about. You need to know how to identify, even on CT, how to identify the vascular territories. So if this area is affected, you know that it is the middle cerebral artery. If it is in the middle, you know it's the ACA, and if it is in the posterior area or in the back or in the in the inferior area, then you know it's a PCA. Most important to know, like a very general, let's say it's a very general refreshing of your memory. ACA will mainly present like in terms of lower limb weakness. MCA will present with weakness in the face and the arm, as well as aphasia. So patients will have problem with speaking. And finally, PCA will present with contralateral homonymous hemianopia with macular sparing. That's a very general classification or a very general refreshing of your memory. But of course, you took all of the details here in the anatomy already. So now let's come to cerebrovascular disease. This is one of the most important slides to understand that stroke is either a thromboembolic or a hemorrhagic. Why is it important? Well, 80% of the patients who are presenting to the ER will have a thromboembolic infarction. So you really, for these patients, they are already suffering. You really just want to go and give TPA, which is the thrombolysis therapy, to to lyse the clot, and then the patient will be fine again with some disabilities. But you cannot do that. You really have to do, and you need, even if the patient really just need a TPA, which is 80% of the cases, you cannot give them a TPA before you do a non-contrast CT, because this patient might be one of those unlucky patients who are presenting with a hemorrhagic stroke, which is 20% of the cases. So 80% of our patients will have a thrombotic stroke and they need a TPA, and 20% have a hemorrhagic stroke and it's just a bleeding in the brain, and you cannot give them TPA. You will kill them if you give them a TPA. And for this, every stroke patient presenting to the ER must have a non-contrast CT. This is one of the key principles for managing a stroke. Any patient presenting with signs and symptoms of stroke, you immediately arrange for a non-contrast CT to know whether it is a thromboembolic stroke, 80% of the cases, or a hemorrhagic stroke. We will talk about these details later on as we proceed forward. So stroke is a clinical diagnosis. You really diagnose stroke based on the physical examination and the findings that you pick up on the physical exam. We do the non-contrast CT just to know what's the cause of the stroke. Is it a thrombotic or an embolic or a hemorrhagic stroke? But after all, it's just a clinical syndrome of neurological signs and symptoms that last for more than 24 hours. Because if it is less than 24 hours, then we call it a transient ischemic attack. We will talk about this later as we proceed. So common sites of brain involved in the stroke, basically anywhere. MCA is one of the most common sites, the middle cerebral artery. And we'll talk about why again later. And he is just saying that basically any area of the brain can be affected if the blood supply is interrupted. And that's basically the definition of stroke, an interruption of blood supply, whether it is due to thrombosis, whether it is due to hemorrhage, because in a state of hemorrhage, sometimes people ask, if I have a hemorrhage in the brain, then why am I developing a stroke? Well, basically because this blood is already accumulating in your brain and it's not being oxygenated. So that's like you're not having a blood supply to the brain. So that's the same thing as having as if you have an interruption in the blood supply. I hope everything is clear. If you have any question, just ask immediately. If I'm speaking too fast, just tell me, I'll slow down. I'll try to slow down. So we already talked about that. A stroke is either a TIA if it's less than 24 hours, or it is an ischemic stroke where basically there's an obstruction in one of the vessels, or it's a hemorrhagic stroke where there is a bleeding in one of the vessels. Okay. So now let's move on to the ischemic stroke, and we'll talk about focal cerebral ischemia. So focal means that only one of the vessels in the brain is affected and not the entire blood supply to the brain. So sometimes we will talk later about how we can have like a general state of hypotension, and that will affect the entire brain. Okay, the entire brain will be in a state of stroke. But this is not very common. The most common is that you have only one of the blood vessels is affected, giving you a focal cerebral ischemia. So in focal cerebral ischemia, of course, the clinical presentation will depend on which vessel is already like occluded. So is it the MCA, the ACA, or the PCA, or even the small penetrating vessels? The duration of ischemia is very important, as mentioned here. The duration is extremely important. Of course, the earlier, the better, because like we really need to try to salvage those neurons that are already at risk of necrosis. And also the collateral flow, as we said, the circle of fluids already has a lot of anastomosis, a lot of collateral flow. The more collateral flow that we have, the better outcome, because the obstructed vessels can be compromised by, like we can compromise for the obstructed vessels by the vessels that surround the area of stroke or the area of obstruction. So that's everything about the slide. Again, if you have any question, just ask me. This is just again showing the same concept that the first type of stroke, which is the thromboembolic, can be either due to a thrombosis in the vessel itself. So what is the difference between thrombosis and embolus? Embolus is just like a blood clot that is coming from a distant area from the body. Could be from a DVT, could be from the heart itself, from anywhere. And it just happened to stop at this area and then obstruct the blood vessel in the area distant to it. While a thrombosis is like the cholesterol is building up in the vessel itself at that area. So the origin of the obstruction is in the vessel itself. It's not like here in a distant area from the body. No, here we are developing an obstruction from the area, from the vessel itself. So that's basically the normal process of atherosclerosis that happens everywhere in the body. It can happen in the carotids, and it can give you signs and symptoms of stroke. All right. So that's everything about the slide. Again, showing the same thing, how basically a focal area of obstruction can lead to focal ischemic or focal ischemia. So this is an important diagram. Whatever we do, all of the clinical research, all of the clinical trials that are ongoing right now, and all of the conclusions that we have arrived to is just to show that when we treat a stroke patient, we are not salvaging the areas that are already dead. Whatever is gone is gone. And that's why time is brain. We are trying to salvage those areas that surround the ischemic area. Those areas are already dysfunctional, but if you give them blood supply again, you can revive them, you can bring them back to life. And that's what we are trying to save. That's why in a stroke patient, we need to give a TPA, which is the thrombolysis therapy, not because we want to salvage the necrotic area, this is already gone, but because we want to restore the blood supply to the areas that are at risk of dying. This is what we call the numbra. So you can see that the numbra increases. Okay, look, here we have the cerebral blood flow. At 30, you have a normal function, although it's a very low blood supply, but the brain can maintain its function at a low blood flow. However, if you go beyond the critical point, you'll start to have a functional impairment. And if you increase the time of obstruction, then you'll get more infarction and more necrosis. And that's how the process goes on. So the number is an area between the viable tissue and the necrotic tissue, and that's the area that we are trying to salvage when we treat a stroke patient. This is just again showing the diagram. So you have the ischemic core, that's the area that's already necrotic, it's not salvageable. Okay, we can't do anything about it. And also you have the ischemic penumbra, which is the area of moderate ischemia that surround the ischemic core. So these are the stroke risk factors. You did not take the cardiovascular block, it's in third year, but these are the same risk factor as cardiovascular diseases. We classify them into modifiable and not modifiable. If you want to remember, you need to remember hypertension, smoking, okay, and of course diabetes and cholesterol. Here they are, diabetes and even cholesterol. The non-modifiable risk factor, most two important things are age and gender. So males, of course, are at higher risk for any atherosclerotic disease than female. Females post-menopausal becomes equal to male. Okay, so you can think about it as estrogen in the premenopausal state is a protective factor for females. However, when they become postmenopausal, then they become equal to males. These are the other risk factors. So homocysteine, like it's a well-known disease that causes a high level of thrombosis or hypercoagulable state in the blood. So it increases the chances of stroke, of MI, peripheral vascular disease, any cardiovascular disease you can think about. And these are the risk factor. Of course, patients who already have a TIA are at a huge risk for developing a stroke in the future as well. And we'll talk about them, but that's why we need to give them a special attention. Oral contraceptives, because it gives a hypercoagulable state, so the blood will have a higher tendency to coagulate in any woman who is on OCPs. And sickle cell, those small vessels, they can go into the very small blood vessels and can obstruct them. And when you obstruct them, it can lead to a stroke. I hope that nobody has any question. You can just go and ask immediately. So now let's talk about so we talked about the focal ischemic stroke, we've explained it, okay? And we've talked about the risk factor. Now let's talk about the causes. So what causes a thrombosis to develop in one of the vessels of the brain? Why would one of the vessels become blocked in the brain? So there are many causes. This is the one that we mainly talked about, which is atherosclerosis. So basically just the cholesterol will build up in these vessels and then they will become obstructed over time, leading to a stroke. And then of course, these thrombosis can break off and they become an embolus. And then they can travel elsewhere and they can block another vessels, a distant vessel. Okay, so this is the most common. Okay, and this is the easiest to understand as well. It can happen in extracranial and intracranial vessels, or even in the very small vessels that supply the basal ganglia of the brain. The second, okay, so we're done from atherosclerosis. The second cause of obstruction in the blood supply to the brain is any state of hypercoagulability. The blood just like have a higher tendency to form blood clots, and then these blood clots can obstruct any vessel in the brain. So this would be antiphospholipid syndrome, sickle cell, hematocrit or polycythemia, and even high homocysteine levels. I think from this, if you just remember a hypercoagulable state, it would be more than enough. You don't really need to go into the details of hypercoagulability because you'll take these in details in the hemonc block of third year. Vasculitis, again, this is an entity of like a huge number of diseases that you'll be taking in third year. To simplify it, to make it very simple, it's just when a blood vessel, whether it is small, large, medium size, have an inflammation that is going on. Okay, mostly due to autoimmune disease, sometimes due to infectious causes. So if we have the blood vessel here, there is already a state of inflammation in the blood vessel. This blood vessel will try to repair itself, okay? And this will expose the collagen in the blood vessels, which will lead to coagulation and formation of thrombosis, clots, and can lead to obstruction of the vessel. So any disease of vasculitis, there are many, like polyarteritis nodosa, Wegener's, giant cell arteritis, arteritis of small and large vessels. You can just remember the word vasculitis, it will lead to an ischemic stroke. And it can even lead, we'll talk about that later, it can even lead to a hemorrhagic stroke. So the vessel is already having a state of inflammation, okay? It can become obstructed if there is a lot of repair going on, or it can become very weak and can rupture, leading to a state of hemorrhage. Here, there are just other very rare causes. Sometimes drug abuse, for example, can even lead to an ischemic stroke because it causes severe vasoconstriction. So patients who abuse amphetamines or cocaines, they have severe vasoconstriction in the vessels of the brain, and that can sometimes interrupt the blood supply. So in summary for this slide, what are the causes of ischemic stroke? Atherosclerosis, vasculitis, hypercoagulable states. And you can just know some of the details about them. What about embolic stroke? So we've talked about the thrombotic causes. Now, what about the emboli? So the embolus in general, it can arise from anywhere in the body, but most important cause is the cardiac causes. So patients who have atrial fibrillation, so their atria would not be contracting, they will be fibrillating, which means that they will be doing like this, like not contracting at all. So they will create an area of stasis for the blood to accumulate, and that can form clots, which can go to the brain, stop the blood supply. Okay, patients who have MI, okay, so they already like have a myocardial infarction and the ventricles this time is not contracting very well. Again, there will be an area of stasis for the blood. A clot will form in the heart, and then it can goes onto the brain. Okay, any valvular disease can create the same problem, causing stasis of the blood, and we've talked about atrial fibrillation. If you want to remember anything of this, just remember any cardiac cause can cause a thrombus to form because of stasis of the blood, and especially remember atrial fibrillation because like any board exam or even any university exam like to talk about atrial fibrillation. Just to know that this is a state where you forms a lot of blood clots if the patient is not on warfarin, okay, and this can lead to a stroke. Artery to artery, this is what one of you guys mentioned in the chat, Sarah. So this is basically when an artery develops a thrombosis, and then this thrombosis, we've talked about that, how cholesterol builds up and so on. It can suddenly, like due to a trauma or due to anything, if it becomes very weak, it can suddenly breaks off and goes onto any distant area like the brain and then causes a state of embolic stroke. Sometimes DVT, although this is in the veins, but if the patient develops DVT and he has a paradoxical embolism, which means that he has an opening in the heart that allows blood to go from the venous to the arterial side, then they can develop a state of embolic stroke. This is usually in patients who have either patent foramen ovale or atrial septal defect or ventricular septal defect. And sometimes even fat emboli, this is very rare cause. It happens when there is like a fracture of the long bones. I think you already took that in hematology in first year. So that's everything about emboli. So to summarize these two slides, because they are important, thrombosis happen either because of atherosclerosis, hypercoagulable state, or vasculitis. We've explained each one of them in details. While embolic stroke, it happens due to either cardiac origin, most importantly atrial fibrillation, or due to a breakup of a thrombus from an artery, and then if it dislodged in another artery. So these two slides are very important. I'm not going to go into the details. This is too much detail. You can skip it as well. And again, I told you most important about that is to know the homunculus, so that if I told you the patient is presenting with contralateral lower limb weakness, like let's say right lower limb weakness, then where is the stroke or where is the obstruction? Then you need to know that it is on the left side and it's most likely in the anterior cerebral artery, because that's the area that supplies the lower limb, or that's the area in the homunculus that is responsible for lower limb. So you need just to know the homunculus so that you can correlate the clinical presentation with the artery that is obstructed. Other than that, you can skip this slide. If you know the homunculus very well and you know the structures of the brain, then you can skip these two slides. What is the watershed infarction? This is the area that receives the blood supply from two distant main arteries, but this is like, the very end of supply. So that, like, for example, this strip of area, it's received the very distal end of the MCA and the very distal end of the ACA. This is a very important question, when do these areas get affected? When do patients get what we call a watershed infarction? It is in any state of hypotension. So in terms of board exams, USMLE usually will tell you that the patient underwent a cardiac surgery. So in cardiac surgery, patient usually become very hypertensive, just to operate and so on, or in a state of bleeding, or in a state of shock, or in a state of anaphylaxis. So all of this will lead to a very low blood pressure. And when you have a very low blood pressure, then this area will be like very compromised and they will develop a state of infarction and a state of stroke, because usually they depend on high blood pressure or adequate blood pressure to maintain their perfusion. Okay, pseudolaminar necrosis is really not much than, really don't need to know anything about it. It's just that, the different areas, different layers of the cortex, like, can be compromised at different areas of infarction. and can create, a pattern of area of necrosis and then normal cells, necrosis and normal cells. You can just skip it. It's really nothing important. Any questions so far? Am I going too fast? Is it okay? Should I go faster? All right, I'll continue. So we've talked about the causes of ischemic infarction. Now, how do we identify these patients in the ER? So they come with signs and symptoms of stroke. We do the physical exam and we suspect that they have a stroke. We do the CT scan. If it was a hemorrhage, that's a very important concept. Even it comes in SAQs and even in MCQs. If it's a hemorrhage, then it will be immediately visible on the CT. You will see a bright area. Of course, we're giving no contrast. We don't give contrast in patients who we suspect that they have a stroke. So it will be an immediate bright area if it's a hemorrhagic stroke. If it is an ischemic stroke, it will either show some changes, like the area will appear darker a little bit, or if it's very early, it will show no change on CT, like this CT. So what do we do in this case? We either repeat the CT a few hours later, or we can do this advanced way of imaging, which is not available everywhere, which is called MRI diffusion weighted imaging. So this can identify even early changes on CT scan. Okay. So the key concept to take from this slide, if a patient is presenting with a stroke, you do the non-contrast CT. If you found that there is no hemorrhage, you can proceed with the TPA. Best, however, you don't if the CT was totally normal, then you cannot say that he does not have a stroke, because it might be very early that it's even not detectable on CT. So you either wait for a few hours, or sometimes, like rarely, they go for the MRI imaging, this type of imaging, to identify early infarction. Okay, so hypertensive cerebrovascular disease is an entire entity. How can hypertension lead to a stroke? So many patients that we see in everyday life, they have hypertension. How does hypertension predispose them to a stroke? It's actually through a variety of causes. Just give me a second. I need to stop for a second. All right, back again. So hypertension. So we're saying that how does hypertension lead to a state of stroke? We've already talked about the first mechanism. First, you need to understand that of all the risk factors, hypertension is the most important to control in order to decrease the stroke level. That's what the most recent clinical trials have shown. That's why any patient who is hypertensive, it's very important to control their blood pressure. Because hypertension, number one, it either accelerates the process of atherosclerosis and developing thrombosis. That's the process that we've already talked about in the first few slides. That's number one. Number two, hypertension can lead to what we call hyaline arteriolosclerosis. Now, what does that mean? Okay, hyaline is this pink area that develops around the blood vessels. This is a blood vessel in the brain. These are all neurons. This is the blood vessel in the brain, and this is what we call hyaline arteriolosclerosis or lipohyalinosis. So when we have high blood pressure, all of the protein that is in the blood will be pushed away to the periphery, and then over time they start to accumulate in this pinkish area, and that's what we call lipohyalinosis or hyaline arteriolosclerosis. When this protein accumulates, giving us this pinkish area, or here it's much more clear, and it's very prominent. When this develops, the vessel will become either very weakened, okay, or will become very thick that it can become, thrombosed. It can become obstructed. So that's the second way. This is most important where is hyaline arteriolosclerosis mostly significant. It's most important in the very small vessels, the vessels that supply the basal ganglia, the deep structures of the brain, and we call this a lacunar stroke. We will talk about it in a few slides. The third thing is that hypertension can lead to Charcot-Bouchard aneurysm, microaneurysm. So this is just a blood vessel that is chronically exposed to very high pressure. Okay, that the blood vessel will start to develop kind of balloons, and these balloons can rupture at any time. And this is how can hypertension lead to a state of stroke. Okay, so these are the three main pathological process or pathophysiological process of how can hypertension lead to a state of stroke: atherosclerosis, lipohyalinosis, and Charcot-Bouchard aneurysm. Okay, the first two usually lead to an ischemic stroke, while Charcot-Bouchard aneurysm usually lead to a state of hemorrhage. And it's coming at the very end of the lecture. Okay, this is a slide that is not in its place. It's just showing how this balloon, which is the Charcot-Bouchard aneurysm, the aneurysm that developed because of chronic hypertension, can suddenly rupture and lead to a state of hemorrhage. When does that usually happen? In terms of board exams, they usually like to tell you that a father was fighting with his son, like on a state of business or selling something or selling the house or whatever, and then he suddenly developed signs of stroke. And then they mention in the history that the father is hypertensive. So you know that the cause is most likely a rupture of a Charcot-Bouchard aneurysm. Okay. Next is the lacunar stroke. So this is this one, which is the lipohyalinosis. We said that it leads to lacunar infarction. Let's talk about it more. So lacunar strokes are these very small strokes that happens in the deep area of the brain. These are a few images. So this is a lacunar stroke, and this is another one. Okay, usually it happens, as we said, in hypertensive patients. You need to know, you need to remember this fact. How does that happen? Again, hypertension leads to the accumulation of hyaline and the formation of lipohyalinosis, which is this thing that we talked about, the pinkish material that develops around the blood vessels. This is what we call hyaline arteriolosclerosis or lipohyalinosis. And then when it develops, usually the vessels get weakened, and then it can lead either to rupture or thrombosis of the vessel. Okay, they are usually very small, so less than 1.5 centimeter, and they're usually multiple. Okay, so because these if you know the anatomy, the lenticular striate arteries, that they branch from the main vessels and then they go like this to supply the deep area of the brain. So like multiple of them, many of them can develop small infarctions. How do they usually present? So the most important to know is that they present with signs of motor weakness most commonly. If it is big enough, so why do they present with motor weakness? Because it affects the internal capsule. Okay, and we know that the internal capsule has all the fibers that are coming from the cortex and then going down to the brainstem and so on. So if these fibers got affected, patient will present with contralateral weakness or paralysis. Sometimes they present with sensory stroke as well, with sensory symptoms. And when does that happen? If the infarction is big enough to affect the area surrounding the internal capsule, which is the thalamus. And we know that the thalamus is the major area for sensory information in the brain. So if it affects the thalamus, then it can present with contralateral sensory loss as well. So how can we distinguish lacunar strokes from, let's say, MCA stroke, which also present with signs of weakness or sensory loss? Well, most importantly is that these lacunar strokes do not have cortical signs. What do we mean by cortical signs? Aphasia, because the cortex is responsible for speaking. So aphasia is one of the cortical signs. These patients will not have aphasia. Neglect syndromes. So again, this usually develops in the non-dominant parietal hemisphere anyway. So lacunar strokes do not have syndromes of neglect or aphasia or astereognosia. All of these are what we call cortical signs. So all of them will be negative in lacunar strokes because the cortex is spared, it's not affected. What is affected is what is down, like what's beyond the cortex, which is these basal ganglia and small structures in the brain. I have something in the chat. So is lacunar stroke just a name for the stroke that happens in small vessels because of hypertension? You can say yes. It's one of the, like, yes, you can say yes. So lacunar stroke are these small strokes that develop in the penetrating vessels, and most common cause is hypertension. Yes, that's true. And of course, when these, like, when time passes and these strokes already happened, if you do an autopsy on the brain, you'll find what we call slit hemorrhages, which are these small, openings. So they're just, the residual of these small strokes. They're just slit-like cavities. Now, if we do an autopsy for a stroke patient, we can identify the time at which the stroke happened by these morphological changes. So to summarize them very quickly, in general, the brain will be swollen and edematous, okay? So that's why they're saying that it's gonna be wide gyri and narrowed sulci because the brain has a lot of water and it's very edematous. It's almost in a state of inflammation, okay? It's very difficult to distinguish gray and white matter. That's on the very gross appearance. If you bring a slide under the microscope to check for histology, in the first 12 to 24 hours, you will find what we call the red neurons. That's a very important term to remember. That happens in the very first few hours, 12 to 24 hours. So before 12 hours, usually there will be no change, no histological changes. After 12 hours, red neurons start to develop. And what are red neurons? They are basically the dying neurons. We know that on hematoxylin and on eosin, the nucleus stains purple while the cytoplasm stains pink. When the when the cell die, the cytoplasm will start to shrink. So this pinkish material that was distributed over all the cytoplasm now will be shrinking, and then it will become very condensed, leading to the concept of red neurons. And of course, the nucleus will disappear because it's a dying neuron. Okay, so that's the red neurons. It develops in the first 24 hours. Then after that, you will find a state of inflammation. This is the normal state of inflammation that you took in POD. So neutrophils will first emerge in the first 3 days, and then macrophages in the 3 to 7 days. Neutrophils will just make sure that they bring, they start to, start to create a state of inflammation and bring more proteins and more fighting cells, while macrophages will start to eat up all the debris, okay? And then after that, you'll have, this is special in the central nervous system, you'll have reactive gliosis. So all of the astrocytes that surround the area of stroke will start, to proliferate, and this produces this a gliosis, which is like a fibrosis. And then after 2 weeks, everything will be cleared. The macrophages will eat up, will have already eaten up the entire area. And you sometimes like end up with just the cavity, or with the gliosis, which is the fibrotic area around the stroke. All right. So we've already covered hypertension very well. A quick summary: it's either atherosclerosis or lacunar infarction, which is small vessel disease, or it is acute, that's in the long term, okay? Or it is acute, which is the intracerebral hemorrhage or hypertensive encephalopathy. I think we're very slow. I'll try to fasten up. So now this is the clinical part of the lecture. How do we manage a stroke patient? Of course, the first thing is you need to diagnose the thing before we treat it. So how do we diagnose a stroke? This is very important, not for your exam, but for your own loved ones and family members. You need to identify a stroke as early as possible, because time is brain. You ask them to smile, okay? And then if they have a drooping in one of the ankles, then you know that they are potential candidates for a stroke patient, God forbid, of course. You ask them to raise their arms, both of their arms, and then you'll find that there's a difference between both of the arms. Then you, of course, suspect a stroke. You ask them to speak, and then they'll either be confused or they'll develop very heavy speech, okay? It's gonna be very difficult for them to speak. And then if you develop any of these, if you see someone with any of these signs, then you need to immediately call the emergency and take them to the hospital. So that's the mnemonic FAST for stroke. Of course, this is just to tell you that with every minute that passes on, you're losing millions and millions of neurons, and that's why time is muscle. Sorry, that's for the heart. Time is brain for the CNS. So after we diagnose, now, how do we diagnose stroke patient? A patient presenting to the ER with signs and symptoms of stroke, the most important single question to ask is, when was the last time the patient was seen normal? So it's not when did it start, like as we say in Socrates, it's not what did the patient develop or what are the chronic risk factors for the patient. It is when was the last time the patient was seen normal. And why is that the most important question? Because the patient could be sleeping for 8 hours and then they suddenly wake up with signs and symptoms of stroke. The stroke could have happened anytime during these 8 hours. You don't know exactly. So we don't ask when did the thing happen, when did the stroke happen, because we might not know. We ask, when did you see the last time the patient was normal? So they might say, it was on the dinner at 10 p.m. last day. And so that we can know how can we proceed further with the management. And of course, that's the question that is very important, because we need to make sure whether this patient is a candidate for TPA or not. Okay. Now, so ischemic stroke, you diagnose them if it is an acute onset focal neurological deficit. The patient has a lot of risk factor like diabetes, hypertension, smoking, cholesterol, everything. Once you identify them on physical exam, you go for non-contrast CT. You at the same time order blood tests, blood sugar, BUN, creatinine, electrolytes, all routine blood tests. Why is that important? That's again one of the questions that can sometimes present in ER board exams. And no, blood sugar is very important. Sometimes the patient is just hypoglycemic and he's presenting with signs and symptoms of stroke. So he's not actually in a stroke, he's just hypoglycemic. Just give him some sugar and he will be fine. That's why they immediately, when a patient presents with these symptoms, they immediately do a finger stick glucose test so that to check if the patient is hypoglycemic or not. And then they do some cardiac testing, again, as routine tests. So these are the deficits that you can see on physical exam. We've already talked about most of these. These are the areas of the brain that can be affected by stroke: the arms, the legs, the face, the speech, anything basically. What is the most common presentation for stroke? We said face weakness, hemiplegia or hemiparesis on one side of the bodies, and sometimes aphasia when the dominant hemisphere, when the cortex is affected. Okay, the limbs are usually first flaccid, so it's kind of lower motor neuron lesions at the very first few hours, but then after several days it turns up because it's an upper motor lesion, so it turns up into an extensor plantar response and an exaggerated reflexes. It becomes an upper motor neuron type of injury. Okay. So this is NIHSS patients, for consultants who are expert in managing stroke, they can do the NIHSS scales at like almost 2 to 3 minutes. And it detects how severe is the stroke like at the immediate presentation. So they do all of this checkup in just a matter of few minutes. And you don't really, of course, you don't need to know them, just like you can maybe memorize the name of the scale. And to determine the final outcome after the stroke, we can use the modified Rankin scale. So what are the conditions that can mimic a stroke? Of course, you need to make sure that it's a stroke before you treat it with a TPA. Otherwise, you will kill the patient sometimes if you give them a TPA and they develop a hemorrhage. So Bell's palsy because it presents with signs of face weakness. So there will be a drooping of the ankle of the mouse and you can think that this is a stroke. Well, this is just a Bell's palsy, which is a very common condition and it resolves by itself most of the times. It's just a facial paralysis, facial nerve paralysis. Thought paralysis happens after a seizure. So a patient can develop seizure and then after that he'll have a limb weakness. You can think that this is a stroke, but this is not a case. This is just a thought paralysis that will resolve over time. Okay, it usually resolves within 48 hours. So again, you don't need to treat them with a thrombolytic therapy at this time. Okay, of course, you'll not be required to to know how to differentiate between a thoughts paralysis and a stroke, but this is just for your information. No, there are a lot of mimickers for a stroke. Not every patient with weakness is a stroke. Okay. Again, we said how hypoglycemia can present with signs of confusion and weakness, metabolic conditions, anything. Sometimes psychogenic, so patients can present with the feeling of very heavy arms or very heavy leg. We call this convergent disorder, okay? It's just that they feel that they have a neurological disease, but they don't actually. Again, hypertensive crisis and complicated migraines all can mimic a stroke syndrome. So how do we support these patients once we receive them in the ER? Of course, the normal ABCs for any ER condition, airway, breathing, and circulation. Okay, you don't want to treat the stroke, but the patient is not breathing. Otherwise, he'll be dying. You need to treat anything that the patient has. So if they have a fever, give them antipyretic. Hypertension, we will talk about it. It's very special. So we don't manage every hypertension patient at the time of the stroke. Okay, sometimes it can lead to like bad outcomes. We will talk about that later. If they are hypertensive, you can just give them fluids and you treat any underlying disease that they are presenting with. Next, we move on to the acute treatment, and this is important for you. So after the CT is done, and we exclude that it's a hemorrhage, then we can give the TPA. This picture is not very clear, but it can just identify some of the focal changes, but there are a lot of clearer pictures that can tell you, how to identify stroke on CT. This is not a very clear picture. So we've already explained that concept. No, we are not trying to save the dead neurons, but we're trying to save the area that is around the dead neurons. Okay, and that's why we need immediately to give a TPA as early as possible. That's the concept of NUMBRA. Okay, so this area is already dead, but we're trying to save this black area. So what can we do for an ischemic stroke? Of course, the most important thing about treatment is the tissue plasminogen activator, the recombinant TPA. Usually it's given in the first 3 to, actually this is not accurate, it's 3 to 4.5 hours, okay? And we say that the expected response time is 60 minutes from door to needle. So once you receive the patient in the ER to the time you inject the needle of TPA, it should be less than 60 minutes. And that's the typical course. So you identify the patients at the time of onset, okay? At less than 25 minutes, you need to be done with your history and physical, and you already managed to do some blood tests and do the CT scan. The time the CT will be performed to the time the radiology reads it should be less than 20 minutes, and then TPA should be administered in less than 15 minutes. If you add up all of these, 25, 20, and 15, it should be in less than 60 minutes. That's the typical course of a stroke, but of course we are far not reaching that level yet. Just give me a second. Okay, sorry for the interruption. So this is just a clinical trial showing that the earlier you respond to a stroke patient, the better the outcome you'll have at like 3, 4, 5, 6 months interval. You really not need to worry about the graph. Okay, so once you give a TPA, of course, TPA has a lot of advantage if it's an ischemic stroke, but at the same time, you need to make sure that the patient does not develop signs of bleeding, okay, and there is no transformation into hemorrhagic stroke. So you need to do a neurological assessment every 15 minutes for the first 2 hours, every 30 minutes for 6 hours, and then every hour until you complete like the first 24 hours. If the patient starts to develop signs of nausea and vomiting, then you know that these are signs of increased intracerebral pressure, and then you might suspect that the patient has a bleeding in the brain, an intracerebral hemorrhage, and then he might have, transformed into a hemorrhagic stroke, and you need to order an immediate CT for the brain. Okay, this is just again.
There's a question in chat. So should we give TPA in 3 to 4.5 hours or in less than 60?
No, the 60 is just the time. The 60 is just the time that we need to give the TPA in the ER. I mean, if we receive the patient and we already found that he has a stroke, let's say in less than an hour, then in another hour TPA should be already given. You can forget about the 60 minutes. It's just, they just measure how efficient are emergency departments and so on, and they compare like one stroke center to another. But TPA should be given in 3 to 4.5 hours. That's the most important number to memorize for your exam regarding this lecture. Okay, so blood pressure should be maintained below 180 systolic and below 105 diastolic. Why we don't lower it further, less than 120/80, which is the typical blood pressure? Because sometimes the penumbra, which is the area that is very sensitive to ischemia, is maintaining adequate perfusion because of the high blood pressure. If you bring blood pressure to normal, back to normal, then the patient might develop further ischemia. Okay, so that's why we cannot really lower the blood pressure that much. We need, if the patient is having a very high blood pressure above 180, then yes, we try to lower it a little bit down, but we don't lower it to the level of the normal, because at this level, patient, a lot of area of ischemic area can become compromised. Okay, so after we treat acute stroke, we need to manage the neurological complications. What are the complications that can happen because of a stroke? Seizures, hemorrhagic transformation, and cerebral edema. We've talked about hemorrhagic transformation. The vessels and the neurons are already ischemic and they're already very weak. At any time, the blood vessels can break open and the hemorrhage can occur. Okay, seizures can develop because seizure is just an abnormal electrical activity. If there is any change in the structure or the function of the neurons, a seizure can develop. So we need to manage it. And the cerebral edema, we will talk how to manage it. We'll talk about that right now. So how to manage cerebral edema? We just need to lower the intracranial pressure so that the patient do not develop signs of herniation that can lead to immediate death. So these are some of the techniques that can be used clinically. We can sometimes elevate the head of the bed. We avoid anything that could compress the jugular veins and thus compromise the drainage of the brain blood supply. We avoid hypoxia, and sometimes we intubate the patient, because if the patient becomes hypoxic, then the cerebral blood vessels would dilate to increase the blood flow to the brain. We don't want that to happen right now because the patient already has a very high intracranial pressure. So we avoid hypoxia and we avoid any hypotonic solution because fluids will go into the inside of the cells and that will make the brain swell more and more. Secondary prevention of a stroke. So this is just telling you that a patient who already developed a stroke is at very high risk of developing a recurrent stroke or any cardiac events in the future, next month, year, and 5 years. That's why we need to control all of these risk factors so that we prevent the development of another stroke. All right, so what about medical secondary prevention? So this is just lifestyle and also managing risk factors. But this is the medical treatment. So we sometimes place them on antiplatelets, either aspirin or clopidogrel, which is again a type of antiplatelet therapy. It prevents the development of platelet clots. Sometimes we give them aspirin and dipyridamole. Again, dipyridamole is a phosphodiesterase inhibitor that prevents platelet interaction with each other and prevent clot development. So we have 3 treatment options. That's after the patient developed the stroke. We can give them any of these 3 treatments. We also control the risk factor, and that's very important. Hypertension, diabetes, smoking, lipids, lifestyle, stress, and obesity. All of the risk factors should be controlled so that they don't develop another stroke. Now, what about anticoagulation? So patients who develop a stroke, do we place them on warfarin or heparin? The answer is no, except in few cases. So we place them on warfarin, which is vitamin K inhibitors, or NOAC. NOAC are the new drugs that are replacing warfarin, novel oral anticoagulants, because they don't require monitoring. When you give patient warfarin, you need to maintain the INR at 2 to 3, and so you need to monitor the patients regularly. While when you give NOAC, you don't really need to treat the patient. Anyway, we give any of these options only if the patient has a cardiac cause. So like he has atrial fibrillation or has myocardial infarction and he's at a state of developing distant emboli, then we can place the patient on anticoagulation, okay? However, chronic heparin use is not recommended in a state of stroke because although it can reduces the chances of the formation of another ischemic stroke, it can increase the chances of hemorrhagic transformation, and we don't want that to happen. Recent clinical trials have shown that heparin has actually no increase. Administration of heparin does not actually reduces mortality. Okay, it might benefit the patient in the near term, but at the long term, it does not decreases the mortality because more patients develop bleeding in the brain. So routine anticoagulation is not recommended in ischemic stroke, in moderate to severe stroke, in patients who are given TPA in the first 24 hours, okay? And at any, whatever is the cause, whether we decided to give anticoagulation or not, we never give them if the cause is a hemorrhage. If the cause is a hemorrhagic stroke, you don't want to increase the chance of bleeding and the patient is already bleeding, okay? You will be killing the patient otherwise. These are contraindication to anticoagulation if the patient have a large infarction, uncontrolled hypertension, or microvascular changes in the brain. So when do we consider heparin or anticoagulation? Again, as we said, if it is a cardiac cause, like myocardial infarction, atrial fibrillation, valve disease, or atrial thrombosis. If there is a dissection of the arteries, okay, so it's splitting of the layers, sometimes embolus can develop here and we need to give anticoagulation. If the cause of the stroke is a sinus thrombosis, there's one slide about that, then we can give anticoagulation. Or if the cause of a stroke is a hypercoagulable state like protein C or S deficiency, then we can give heparin. So just a quick summary about anticoagulation. We don't give them in a state of acute stroke. If we excluded the major contraindications like hemorrhage or large infarction or uncontrolled hypertension, then yes, we can give anticoagulation only in selected patients, mainly those who have cardioembolic disease or venous thrombosis or coagulopathy. If it's not clear, I can repeat it. Otherwise, I'll proceed. So another form of secondary prevention is to do cardiac endarterectomy. This is just a surgical procedure where we take the carotid, we stop the blood supply to the carotid, and then we open it up. We remove all the cholesterol plaques. Okay, we revascularize the vessel surgically, and then we put it back to the patients, and then he'll have like a disease-free carotid artery. Okay, this is a very high risk procedure, so it's only recommended in patients who have a stenosis in the carotids of more than 70 to 99%, and sometimes at a lower evidence level between 50 and 70%. But we don't do it for every patient because almost any of your patients will have a degree of stenosis in their carotids, especially if they are at older age. So we don't do it for patients who have less than 15% stenosis in the carotids. We do it only for those who have a higher degree or higher percent of stenosis. If you don't want to go for this high-risk surgical procedure, another option is just to go with the catheter and then you place a stent in the carotid. And sometimes, but this is rarely done, and it's not even recommended that much. Sometimes you can make an anastomosis between vessels so that you can bypass the thrombosis in one of the major arteries, like the internal carotids. Okay, so we're done from ischemic stroke. We'll talk quickly about hemorrhagic stroke. So this represents only 20% of the stroke entities or the stroke patients. Nevertheless, we need to identify them in order to avoid giving them TPA. And we'll talk about how do we manage them if we're not giving them TPA. So the hemorrhagic stroke, the good thing about it is that it can be identified immediately on CT. Okay, even if the stroke is very acute, you can see an area of bright hemorrhage, and you know at that time that you're not giving TPA for this patient. So this is just as this is just, you know, the histopathology and the gross morphology. Someone told me in the chat that you already took like an entire lecture about the histopathology, so I'm not going to go into details, but just know, you know, when the hemorrhage happens, it's going to be a dark area, and then after the macrophages eat up all the debris, it's going to develop into a cyst in the brain. That's the summary of the entire slide. So, and one of the microscopic changes as well is that the macrophages will eat up the blood that has already hemorrhaged. Okay, so they're going to become pigment-laden macrophages, and they're going to also eat up the dead neurons. Okay, so it's going to be lipid-laden macrophages, and that's one of the step one exam questions. You know, they tell you which of these cells have the potential, you know, if you analyze them, have the potential to be full of lipids, and the answer is macrophages, because macrophages, when there is a state of stroke or any insult to the brain, they will eat up the neurons, and then they will become full of lipid, because we know that neurons are made up of lipids. So, all right, so this is just a summary of the thing. You know that the infarction, okay, could be either hemorrhagic, which is red infarction on gross morphology or gross pathology, or it could be non-hemorrhagic. If it's a hemorrhagic infarction, then TPA is contraindicated, okay? And if it is non-hemorrhagic, then we can proceed with TPA, because the non-hemorrhagic one is the one that we've been talking about the entire lecture. This is usually the one that is associated with thrombosis. This is a new information. You know, the hemorrhagic infarction usually happens after an embolus. So an embolus would lodge from a distant area in the body, and then it will block one of the vessels. And when it does, the vessel behind it will become very weak, and then after that, it can, you know, undergo hemorrhagic transformation and will become a hemorrhagic infarction. So these are small things about stroke. Does anyone have any question before we proceed? Okay, I'll take silence as a no.
Doctor, can you repeat how the hemorrhagic stroke forms from the ischemic stroke or from the embolus?
Yeah, sure thing. So whenever we have an ischemic stroke, okay, regardless of the cause, one of the major complications is a hemorrhagic transformation. That's why we are very worried about giving the right dose of TPA and about whether we give heparin or not, because these areas, including the blood vessels, are very weak, so they can rupture at any moment, and then we'll have a hemorrhagic transformation. And then we'll proceed from a non-hemorrhagic infarction, which is the pale one, this one, into a hemorrhagic one. Okay, and that's the totally new. It's kind of the patient developed a new stroke.
Okay, thank you.
Okay, so why don't we give stroke patient anticoagulation? Wouldn't that help them? So as I said, we might think that it helped them with, you know, managing the ischemia and, you know, preventing a new stroke from new clots from developing. But at the very long term, no, they do not benefit, because you are also increasing. Otherwise, we don't give routine heparin or warfarin. For secondary prevention, we do like instead give them antiplatelets like aspirin, the three options that we talked about. So aspirin or clopidogrel, or aspirin and dipyridamole. So this is just for secondary prevention. It's not anticoagulants. These are not heparin or warfarin, but they're just antiplatelet agents. So they decreases the chance of clots formation or platelet interaction with each other. Okay. So for the venous infarction, this is a rare, these are just rare cases where stroke could develop. And no, you're basically blocking the drainage of the brain. And then again, you are accumulating an area of deoxygenated blood. That's basically a state of stroke, because you are not refreshing the oxygen to the brain. So it's just when there's an obstruction in one of the, let's say, major dural sinuses, and you need to have like a big vein to be obstructed in order to develop a state of stroke. When do we see it? The classical clinical scenario is a patient who is either pregnant, and then after delivery, like she develops signs of stroke, because, you know, pregnancy is a hypercoagulable state, so it increases the chance of venous obstruction and venous like clot formation. Or a woman who is on OCPs, because again, OCPs can increase the chances of hypercoagulability. Now, these are the non-septic causes, okay? basically any hypercoagulable state. Sometimes patient can develop venous infarction if they are septic, okay? So if there is a spread from infection from a nearby area like the middle ear or the nasal sinuses, this inflammation and this process can go on and obstruct one of the veins and lead to a state of venous infarction. You can just skip this slide. It's not very important if you already understood it. Okay, now we are talking about hemorrhagic stroke, okay? We classify them based on the location. Most importantly is either subarachnoid hemorrhage or intracranial hemorrhage. So the intracranial hemorrhage is when there is bleeding inside the brain parenchyma, okay? And subarachnoid space is when there's a bleeding in the subarachnoid area between the pia and the arachnoid matter. So what are the causes of intracranial hemorrhage? Number one is hypertension, and that's the most important risk factor, and it's the most common cause for intracranial hemorrhage. Other less common causes are vasculopathy, amyloid, and aneurysms and vasculitis, and we'll talk about each of them in detail. Okay, but again, the most important one is hypertension. And if you remember the mechanism that we've mentioned in the very first few slides, so we said that hypertension can either lead to ischemic stroke by the development of either lipohyalinosis or accelerated atherosclerosis, or hypertension can lead to Charcot-Bouchard aneurysm. And if these aneurysms rupture, then here we have the hemorrhagic stroke. Okay, so again, we continue the spectrum that we talked about of hypertensive cerebrovascular disease. We talked about atherosclerosis, lipohyalinosis, Charcot-Bouchard aneurysm. Now we have hypertensive encephalopathy. This is not a state of stroke, but it's a state where the brain becomes dysfunctional because of the very high blood pressure. So the patients come with what we call hypertensive emergency when the blood pressure is more than 180/120, and then they start to have signs of confusion, headache, vomiting, because of the very high cerebral pressure, convulsions, and sometimes they go into a state of coma. Okay, and why is that? Because they are having brain edema, they're having very high blood pressure, and sometimes they even develop herniation because of the very high blood pressure. Again, under the spectrum of hypertensive cerebrovascular disease, we have the multi-infarct dementia, or what we call the vascular dementia. This is when small strokes happen because of hypertension, and then over time, because of the accumulation of these very small strokes, patients start to have a form of dementia as if they are having Alzheimer. Okay, you can skip the entire slide. It's not even related to stroke lecture. So this is a typical case of a small hemorrhagic stroke. And we said that we can identify it immediately on CT. Once we see that thing, we don't give patient TPA. Okay. For this one, what do you see on morphology? You see just the blood accumulating in the area, blood clot will develop, and then over time, the macrophages will eat up the entire thing. And then after that, you'll have a cystic area. So if you do a postpartum analysis, you'll find a cyst in the brain. You know that a stroke has happened in this area. While if you do a microscopic analysis, you will see that there are macrophages that are filled up with either lipid, as we said, or they are filled up with pigment, which is basically eating up the blood and the hemosiderin and all of the blood components. And for the neurons surrounding the area, you'll see that you'll find that they have anoxic changes. Okay, so they are very ischemic, they are very anoxic. Okay, so we have a question in the chat. So is this a lacunar stroke? So yes, because we said that lacunar stroke, but this is very huge to be a lacunar stroke. But it's the same, kind of process that we said lacunar stroke are the small ones that develop from the penetrating vessels, mainly due to hypertension. This is not really a lacunar stroke. I would say this is just, a hemorrhagic stroke that's happening in the ventricular striate arteries. So, all right, so we talked about how hypertension is the major cause of intraparenchymal hemorrhage. Now, these are the other rare causes. So number one is vascular malformations. Sometimes patients are born with inborn congenital vascular malformations. So they have a tangle of blood vessels, arteries, and veins connected directly to each other. These tangles have a very high blood flow, and thus they are at very risk of rupturing. And when they rupture, you develop a hemorrhagic stroke or an intracerebral hemorrhage. Okay. And by the way, a vascular malformation can either lead to an intraparenchymal hemorrhage, most of the cases, or sometimes it can even lead to a subarachnoid hemorrhage. If it is very near to the meningeal area, then yes, you can develop a subarachnoid hemorrhage. Okay. Amyloid angiopathy. So there are a lot of causes in pathology that can lead to systemic amyloid deposition. So amyloid is just a protein, okay, that can deposit around the blood vessels due to any cause, okay, sometimes due to chronic inflammation, infection, there are many diseases that can lead to amyloidosis. Whatever is the cause, regardless, if the amyloid proteins start to deposit in the vessels of the brain, then they make these vessels very weak and they are prone to rupture. When they rupture, we have an intraparenchymal hemorrhage. How do we identify them? Usually they are elderly patients and they are presenting with very atypical hemorrhage. So they are not in the deep structures of the brain. They are usually, we call them lobar hemorrhages. So most commonly they occur in the frontal lobe and sometimes in the temporal and other lobes. So they are elderly who develop recurrent lobar hemorrhages. And that's how you know clinically that most likely the cause is amyloid angiopathy. We said that cocaine and amphetamine can either lead to severe ischemia, causing an ischemic stroke, or even can sometimes lead to hemorrhage. Any bleeding disorder can lead to a hemorrhage, and the chronic use of anticoagulation, if it is not monitored very well, it can lead to hemorrhage as well. A tumor can sometimes be very vascular, that it can rupture at any time and lead to hemorrhage, and even a trauma to a vessel can lead to a rupture of the vessel and can lead to intraparenchymal hemorrhage. So as a summary of this, what is the most important cause of intraparenchymal or hemorrhagic stroke? It is hypertension due to the Charcot-Bouchard aneurysm rupture. Other less common causes are AV malformation, amyloid, and then the rest are very rare, trauma and tumors and anticoagulation. So how do we manage patients with intracerebral hemorrhage? Again, we cannot give them TPA, so it's mostly a supportive management. Unfortunately, we don't have much to offer to them, except that we need to avoid them from developing new complications, okay? And from deteriorating, of course. So we need just to maintain the airway, of course, to reduce the intracerebral pressure. We said that we don't want them to become hypercapnic so that they don't increase the blood flow to the brain. We need to make sure that they are adequately oxygenated. And we need to prevent aspiration because this is an intracerebral hemorrhage. There's a very high intracranial pressure. So these patients are at a very high chance of vomiting, okay? This is like as if they are having a brain tumor, you know, intracerebral hemorrhage can lead to a vomiting. So if they vomit, we need to prevent aspiration. And then we need to prevent seizures with seizure medication like phenytoin or other equivalents. So what about the blood pressure? Again, if it is very high, we need to lower it slightly. However, in the first 48 hours, we don't need to lower it beyond 15 to 25% of their original value. Why? Because we don't need to have reduced perfusion to the areas that are already at very high risk of dying. Okay, so these again, I'm going to explain this concept again. These is some in case of hemorrhagic stroke or ischemic stroke, some of the areas are at a very high risk of dying. If we reduce the blood pressure very much, then we are already cutting the blood supply to them. They are depending on high blood pressure to maintain their perfusion. If we lower it very much, we're stopping the perfusion completely. So you don't want to make it very high, okay, so that the brain does not swell and edema do not form, and you don't want to develop high intracerebral pressure. But at the same time, you don't want to lower it you don't want to lower it much so that you decrease the perfusion to these sensitive areas. So a rule of thumb, you want to make it at around 160/90 or the mean arterial pressure of less than 130. And you don't want to lower it beyond 25% of their presenting value. This is subdural hematoma. It can sometimes lead to a state of stroke, but we don't classify it under stroke usually, because it most commonly happens in trauma patients, right? So I'm not sure why this slide is here. Maybe he's just want to try, to link the things, just to link everything that you're already taking with the stroke. So how do you manage subdural hematoma? This is not really related to stroke, but we have medical management with to correct any, if the patient have a high bleeding diathesis, we correct it. Or we can have a surgical option, either hematoma evacuation by craniotomy or by burr hole drainage, where you basically make a hole in the skull and you start to drain the hematoma. Vasculitis, I've already talked about it in the very beginning. Again, vasculitis is inflammation of the blood vessels. Because of the chronic repair, the blood vessel can become very weak, and then it can lead to a state of hemorrhage. And again, we mentioned a few slides ago, that vasculitis, it's not written here. Okay, maybe a few slides even back. So we've mentioned that vasculitis is a cause for intracerebral hemorrhage. You really don't want to need to go over the details of vasculitis. Just know that a vasculitis can lead to an intracerebral hemorrhage. Here it's just telling you the different kind. It could be because of an infectious etiology, because of a systemic vasculitis that is happening everywhere and also affecting the brain, or because of primary CNS vasculitis. Sometimes we have patients who develop blood vessel inflammation only in the brain. Okay, and all of these kinds of vasculitis can lead to a hemorrhage or an intracerebral hemorrhage. These are just supportive information. So what is the stroke unit is where they care about the patients who already developed a stroke. And what do? They basically prevent complications. They treat any, they do rehabilitation, in order to reduce the chances of disability. There are multiple types, those that deal with the patient who have a stroke less than 1 week, or chronic stroke units or rehabilitation centers. It's really just for your information. You're not going to be asked about these. Subarachnoid hemorrhage. So we've mentioned that hemorrhagic stroke are either mainly intraparenchymal or subarachnoid. We've talked about all of the causes of the intraparenchymal hemorrhage. So we said most commonly hypertension, Charcot-Bouchard aneurysm, vasculitis, AV malformation, amyloid, and then other rare causes. Now, subarachnoid hemorrhage, it's when there's a bleeding in the area between the pia and the arachnoid. The most common cause for this subarachnoid hemorrhage is perianeurysm. Perianeurysm is just an aneurysm that does not develop because of hypertension. It develops because of other congenital diseases, like those that affect the collagen, like Ehlers-Danlos syndrome, or autosomal dominant polycystic kidney disease, or other collagen disease. So these patients have weakened blood vessels, and thus they can develop these balloon-like structures, most commonly in the anterior circle of Willis, in the anterior communicating artery. When they rupture, they will rupture into the inside of the meninges, and they can present with signs of hemorrhage. Just a tip for you: whenever you see a picture of a brain that is flipped upside down with hemorrhage in this area, like around the circle of Willis, you're most likely presenting with a question regarding subarachnoid hemorrhage. So the answer would most likely be subarachnoid hemorrhage. Not in all of the cases, but just that's just a rule of thumb for your MCQs. So what, just a second. So what we've talked about perianeurysm and how it can lead to subarachnoid hemorrhage. And we've said that why do perianeurysm develop? Because of autosomal dominant polycystic kidney disease, Ehlers-Danlos syndrome, and other rare, like, congenital disease like Marfan or NF1. Sometimes cigarette, alcohol, and hypertension can predispose to perianeurysm, usually, although they are not the main risk factor, like in the case of Charcot-Bouchard. So how do subarachnoid hemorrhage develop? This is just extra information. Basically, they present with everything: headache, dizziness, diplopia, whatever. But most important distinguishing signs are the classical worst headache of my life or thunderclap headache. Whenever you see this word in the question, then you most likely know that you're dealing with a subarachnoid hemorrhage. Also, it's very important to distinguish them from a state of meningitis, because subarachnoid hemorrhage irritate the meninges. So sometimes meninges signs like Brodzinski and Kernick signs are positive, and sometimes they even have photophobia and visual changes. So it sometimes can become slightly difficult to distinguish between a state of meningitis and subarachnoid hemorrhage. They even develop sometimes temperature elevation. So it could be like a little bit tricky to distinguish between them. This is just pictures showing you perianeurysms, and they are telling you that they are weak because there are some layers that are missing inside these aneurysms, so they are prone to rupture. This is again just a picture of perianeurysm here and there. So what are the complications of subarachnoid hemorrhage? After the first bleeding, the patient can develop a rebleeding, or they can develop vasospasm. So after the bleeding, because of the irritation, because of the blood that is everywhere, the vessels will start to contract to minimize the bleeding. So the patient will, now this time they will reverse from a hemorrhagic state into an ischemic state. And that's why we give them a medication called nimodipine. It's a calcium channel blocker in order to prevent this complication, because we don't want the vessels to contract that much and then they become like ischemic. Also, subarachnoid hemorrhage can lead to seizures, and they can lead to hydrocephalus and any other complication. Most important of these are the rebleeding, the vasospasm, and the hydrocephalus. We are almost 9 slides left. So how to prevent the first complication, which is rebleeding, how to prevent this perianeurysm from rebleeding again? We have 2 options. Either we go with endovascular intervention with a catheter, and then we go on until we reach the aneurysmal site in the brain, and then we we fill it with kind of a glue-like substance or medication so that these aneurysms do not bleed again, or we go surgically from outside and we clip these vessels. Okay, we clip these aneurysms from the neck of the aneurysm so that they don't bleed again. This is the AV malformation. This is the congenital, AV malformation. If you remember, what are the most important things that we've talked about? It can lead to either intraparenchymal hemorrhage or subarachnoid hemorrhage if it was very close to the meninges. Sometimes we treat them surgically before complications develop. So there are multiple forms of them. Most importantly is the AV malformation. You can skip the others. They are described as a worm-like vascular channels. They are just arteries and veins that are connected to each other. And of course, they have a high blood flow, and that's why there is a very high chance of bleeding. They present with 3 signs. We call them shake, ache, or bake. So either seizure for shaking, or headache, or hemorrhage for if they break. Okay, and the most common site is the middle cerebral artery. These are just extra small details. You really don't need to worry about them. This is the worm-like appearance of them, either on CT or an angiogram. And this is another type of AV malformation. It's what we call the cavernous angiomas. This is just like a venous malformation this time. This is the amyloid angiopathy. We've already talked about it. So it's just high amyloid. It deposits around the vessels and it weakens the vessels. It usually happens in the elderly, and it leads to an intraparenchymal hemorrhage. Usually they develop recurrent lobar hemorrhages. So this is a very atypical presentation. When you hear that it is lobar, okay, and it is recurrent and they are elderly, then you know that this is an amyloid angiopathy. This is how do they appear on CT scan. Okay, so all of these dots, this is just amyloid depositions. Not gonna go into the prognosis of stroke, just numbers like in facts and figures. And that's the end of the lecture. So I hope it's very clear. If you have any question, you can go in the chat. If you want me to give a summary or do anything, I'm ready to do anything for you.
Do you guys have any questions?
Thank you so much, Doctor.
Sure thing. I hope that you all benefited.
There is one question.
Question near in the clinical. What questions do they usually ask? So most importantly, in terms of clinical, is to distinguish, like, they're not going to go into the details of asking about the very clinical aspects, but you are finishing the neuroscience block. So you need, of course, to know the difference between hemorrhagic and ischemic stroke and why that difference is very important. We've spent most of the lecture talking about that. Okay, and you need to know when to give TPA, so only in cases of ischemic stroke less than 4.5 hours. That's absolutely the single most important question to be asking clinical lectures. Okay, they might be asking about, I don't think they're gonna go into like, when do we anticoagulate or when do we don't, or so on, as they can ask about like, how do we lower the blood pressure? Okay, like to what extent do we lower it that much? Again, TPA, how to identify stroke clinically. And of course, so we said TPA is very important, and also the what to order for a stroke patient. So just let this information stick in your mind, like for your entire medical career. It's a non-contrast CT. Okay, that's a question that many of the consultants love. Is it a contrast or non-contrast? It's always non-contrast CT, so that you can pick up the bleeding if there is any in the brain. I don't think that they go beyond these questions. Yeah. Sure thing. By the way, I advise you also to, like, you saw that sometimes get very complicated in terms of what are the causes of ischemic, what are the causes of intraparenchymal, subarachnoid, whatever. So I advise you to go for the over the first aid over the first 8 page that talks about the different types of intracerebral hemorrhage, and they are mentioned like just word by word. So they mention all the causes of intracerebral hemorrhage and the subarachnoid hemorrhage and so on. So once you understood them, you can just go over these small paragraphs so that you can memorize them very easily. Just a small advice. And yeah, all the best in your final.